Bol Pradnya.
Yeah, ma'am, should we begin?
Yes, I have no problem.
Okay. So, good evening, everyone. Welcome to the Foxy ICOG JOGI Research Methodology Workshop and Journal Club. So we hold it on the every second Tuesday of every month, and we have lot of audience eagerly waiting for this program. So let me introduce the dignitaries for this program. Nilima, can you display the slides, please? I think Paili sir has also joined, the first speaker for this program. Yeah, the next slide, please, Nilima. So we have Dr. Parag Binewala sir, who is the chair of ICOG, Dr. Sheila Mane, who is the chair elect of ICOG. We have Dr. Ashok Kumar, who is the vice chair of ICOG, Dr. Sarita Bhalerao, who is the secretary of ICOG. We have Dr. Sujata Darvi ma'am, who is the editor-in-chief of JOGI, and the convener for today's program, along with Dr. A.G. Radhika, who is also an ICOG member. And I am Dr. Pradnya. I will be the coordinator for this program. So can we have the CVs of all the dignitaries? Nilima? Yeah. So next please. So Dr. A.G. Radhika, she is the National Coordinator for Clinical Research in Foxy. She is the National Corresponding Editor of JOGI. She is a recipient of several awards, including ICOG Visiting Professor Award. She is an expert
Pradnya, very
reviewer.
short. Just make it one or
Yes,
two lines
yes.
for each one.
And several publications. Next, we have the co-convener, Dr. Sujata Darvi ma'am, and she is the editor-in-chief of JOGI. Madam is consultant there. Yeah, and Madam has been is the secretary of MOGS. So, welcome, ma'am. Can we have a few words from the conveners?
Yeah, Radhika, you want to speak first? You can speak, no problem. Radhika, you can unmute. Okay, I think Radhika is not able to unmute. Or I can't figure out. So at an outset, I would like to welcome one and all for this ICOG, Foxy ICOG JOGI CME. And today's program is going to be quite interesting. We have two papers, and one of which is going to be presented by our very senior member, Dr. Paili, and we have another member from Sri Lanka who would be reading on that. And then we have a research methodology topic, which is going to be covered up by the conveners, today's convener, Dr. Pradnya Changede. And at an outset, I would like to express my gratitude to ICOG Chair, Dr. Parag Biniwale and his whole team, and of course my co-convener, Dr. A.G. Radhika, for giving JOGI an opportunity to have this program on every second Tuesday of every month. Okay, so over to Dr. Radhika if you want to have some input to be put in there.
No, very good evening to all. Thank you, Dr. Sujata, and everybody who is here. So I think it's a good idea to just start with this academic session. It's going to be interesting, and we can keep discussing on the way. Thank you so much.
Yes, so thank you so much, ma'am. Let me introduce the Foxy president. Nilima, can we have Dr. Sunita Tandurwadkar, madam's slide? So madam needs no introduction. She is the dynamic president of Foxy, and we have her blessings for all the programs. Even if she cannot join in person, madam always conveys her best wishes. And we can proudly say today that JOGI and ICOG are all going international. We have speaker from Sri Lanka today. So the next introductory slide would be for Dr. Parag Binewala. Sir is the chair of ICOG. He's been the president of Menopause Society,
Thank
Pune.
you, Pradnya. That's okay.
Yes, sir.
Don't
Yes,
waste
sir.
time.
Yeah. Okay, so the next slide, please.
Okay, Pradnya, before you go to the next slide, let me welcome everyone on behalf of ICOG. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to welcome you all for this episode of Foxy ICOG JOGI Research Methodology Program and Journal Club. At the outset, let me compliment Dr. Sujata Dalvi, the editor-in-chief of JOGI, and Dr. A.G. Radhika, our own governing council member, who are putting a lot of efforts to put this program across. A special mention of the coordinator, Dr. Pradnya Changede, who's doing excellent work in the journal and even for this program. I warmly welcome past chairperson of ICOG, Dr. Krishnendu Gupta. Welcome, Dr. Krishnendu, for
Thank you
here.
so
And
much.
it's a pleasure to welcome Dr. Paili. Sir, I'm really curious and I'm waiting to listen to you in this episode of today's program. Today's program is definitely interesting because we have somebody of the stature of Dr. Paili who's going to speak and is going to talk about cervical insufficiency management with elective transvaginal cervicoischemic cerclage. And we also welcome Dr. Oshadi from Sri Lanka, and she's going to talk about adverse outcomes and clinical associations of dengue in pregnancy. And of course, this will be followed by an interesting presentation on AI in literature review by our own Dr. Pradnya Changede. So my best wishes for the program and happy learning, everyone. I welcome the chairperson or the experts for the sessions, Dr. Krishnendu again, Dr. Manju Khemani, and Dr. Abharani Sinha, who will join very, very soon. Over to you, Pradnya.
Yeah. Thank you so much, sir, for those kind words and inspiration. Next, we have the slide of Dr. Suvarna Khadilkar, ma'am. Nilima, can you display that? So we all know Madam is the Secretary General of FOXI. She has been the past president of MOGS. Next slide, please. Next, we have Nilima. We have Dr. Ashok Kumar, sir. He is Director Professor from New Delhi, Atal Bihari Vajpayee Institute, and he is the Vice Chairperson of ICOG. Welcome, sir. Next, I would like to introduce Dr. Sarita Bhalera, ma'am. She is the Secretary of ICOG, Consultant Gynecologist in Mumbai. Madam, would you like to say a few words? Sarita, ma'am? Okay, can we have, is Madam there? Next slide, please, Nilima. So let me invite the three chairpersons. First, we have Dr. Krishnendu Gupta. We all know that sir is a professor and unit head at Vivekananda Institute of Medical Sciences in Kolkata, and he's been the Secretary General of AOFOG, and sir is has so many prestigious positions. Welcome, sir.
Thank you very much.
Next
Thank you.
yeah. Next chairperson is Dr. Abharani Sinha. She is a professor OBGY from Muzaffarpur and an ICOG Governing Council member. Welcome, ma'am. Can we have the next chairperson? Our third chairperson for today is Dr. Manju Khemani. She is a senior director, Department of OBGY from New Delhi. She is an ex-professor at Lady Hardinge Medical College. Welcome, ma'am, and I request the chairpersons to invite the first speaker for today, which is Dr. Paili, sir. May I request Dr. Krishnendu Gupta, sir, to introduce the first speaker?
Well, it's really, thank you very much, Pradnya, and thanks to Jogi, Dr. Sujata, and Dr. Parag, Chair of ICOG, for giving us this opportunity on behalf of Dr. Manju Khemani, as well as Dr. Abharani Sinha, who's yet to join. We thank Jogi and ICOG for this opportunity. What can I say about Professor Paili? I mean, we are honored that he has been so kind to present his original work. And we all know what a brilliant vaginal surgeon he is. And it's only because of his expertise that he can even embark on such procedures and do it with Ellen. So Professor Paili is the past president of the Kerala Federation of Obstetrics and Gynecology. He's a state coordinator of confidential review of maternal deaths Kerala. He's also a consultant in the Rajagiri Hospital, Alway, Ernakulam district, from where this paper is. And of course, his special interests are high-risk pregnancy, endoscopy, pelvic floor, and urogynecology. He's been a teacher of teachers, and we are so proud to have him on this session today. And it's over to Professor Paili for his presentation and on his original work. And also we have Dr. Sauma Ramakrishnan, who's a senior consultant in the same hospital where Professor Paili is, and I did see both of them there together. And so it'll be a wonderful experience for all of us to hear from them firsthand about this wonderful paper on cervical insufficiency management with elective transvaginal cervical isthmic cerclage. Over to Professor Paili, please. Please unmute yourself, Professor Paili. It'll be nice.
Hello, thank you, Krishnendu, and all the galaxy of our Foxy ICOG journal, galaxy of speakers, as well as the great people over there. Thank you very much for this opportunity. I don't want to waste more time because only very limited time we have. And thank you, the journal, as well as ICOG, as well as Foxy, for allowing us to share our experience of cervical cerclage and the new thought that we have. I am sure there may be some difference of opinion may come up regarding whether you will accept our views about it, but let's see what we have to tell you about it. Why we thought of sharing this is, over the last few decades that we have been practicing cervical cerclage, we have come to a conclusion that what people have been talking about is not acceptable to us, not practical, not real. And that is why this revolutionary thinking we are presenting towards you and for your approval or the. We know that there are different levels of cerclage. The commonest that people talk about is the McDonald, as we can see here. A little higher if you go, reflect the bladder a little bit and put the cerclage at the posterior fornix. We call it the Shirodkar. We are proud of that because Shirodkar, the Indian, provided the details about it and showed the results. But of late, the abdominal cerclage, transvaginal cervicoisthmial is what we suggest, but people put it abdominally at the isthmial region, and that's the abdominal cerclage which is taking the limelight now. And people have moved further to say that we can do it laparoscopically or even robotically. Our own suggestion is that we can achieve that level of cerclage by the vaginal route. So we will share our experience in this and go with this. The question that we wanted to present is it possible to put cervicoisthmic cerclage by the vaginal route and get results equivalent to that of cervicoisthmic cerclage put abdominally? If so, why should we open the abdomen or go with laparoscope or with robotics for doing it? That's the question, and we wanted to analyze our experience with it. People say that McDonald and Shirodkar are having equal results. I think there's nothing worse or wrong, more unreal than this one. They are entirely different. But even Shirodkar, when he puts the cerclage at that level, especially in somebody who had really poor cervical integrity, may not hold when it comes to a dilatation of the cervix. So that is why we thought we have to go a little higher than that, above the level of the uterosacral ligaments. That's the cervicoisthmical cerclage, and we'll show you how we can do it vaginally. This will help to avoid a laparotomy or a laparoscopy or a robotic approach. And more than that, this can be done under regional anesthesia. In early pregnancy or interval, we can do it. So that is our experience. I'll just show you a small clip where we do it. Empty the bladder, and then the cervix is held. We have special forceps to hold the cervix, which don't have teeth, but only grooves like the Babcock. Infiltrate a little vasopressin. This is 120 units added to 100 ml, and we use only about 5 to 8 ml. You can incise the vagina with scissors or with knife, reflect the bladder up, especially go to the side so that you can go later medial to the vascular bundle. The space between the two uterosacrals and the posterior fornix you hold with the ralis, cut directly, you have accessed the posterior, the pouch of Douglas, and you can see that the pouch is accessed. Hold the needle tip down, the double swaged needle that is available for cerclage, blunt needle, and make sure this emerges cranial to the uterosacral ligament. Steady the needle before you release the needle holder, and rather than pulling the needle and the tape with you, you push the tissue back. Once you have achieved the end cerclage, the tape around at the level just above the uterosacral ligaments, Then you take the throws, make sure it is snugly fitting on the anterior surface of the cervix or the ischial level, and then tie it 3 knots and finally close out the opening that you made. This is all the procedure we are talking about. And this was first described in 2001, potentially cost effective, and it prevents preterm birth due to refractory cervical insufficiency in resource constrained settings. But it doesn't have to be only resource constrained settings. Anywhere in where obstetrics is practiced, this can be done. Ours is a retrospective case series, a total of 27 cases from November to 15 to December of 2023. And women were included for analysis who underwent elective transvaginal cervical cerclage with previous pregnancy not reaching 28 weeks. Gestational age, despite an elective Shirodka or McDonald cervical cerclage, pregnancy did not go to 28 weeks or beyond. These are the ones which were lost. And multivital gestations were excluded for our analysis. Postoperatively, they are placed under observation for 24 to 48 hours and discharged with no physical or sexual activity restriction. In some of the patients in the beginning, we gave dydrogesterone 10 milligram twice daily, but later on, we don't do that. Only routine antenatal care is recommended for these patients. Elective cesarean is a must for these patients unless pregnancy gets somehow, not ongoing or progressing before 28 weeks, we may terminate it. Cerclage is left undisturbed in situ if the woman desires to have another pregnancy. Otherwise, it may be removed during the cesarean that we do. So my colleague Soumya will tell you about the patient details.
Good evening all. I'm Dr. Soumya Ramakrishnan. So we had a total sample size of 27. Among our patients, the mean gravidity was 3 plus or minus 1. Among these 27 patients, we had a total of 104 pregnancies. Among these 104 pregnancies, only 3 pregnancies were resulted in live births. The gestational age of immediate past failed pregnancy with previous cervical cerclage, we had there were 3 losses between 10 to 14 weeks, 11 losses between 14 plus 1 to 20 weeks, 8 losses between 20 plus 1 to 24 weeks, 5 losses between 24 plus 1 to 28 weeks. Among these patients, 2 patients had previous history of laparoscopic surgeries, 4 patients had lower segment cesarean delivery, 1 patient had past history of cervical surgery. Coming to the gestational age at which we did the procedure, 4 patients, the procedure was done preconceptionally. For 3 patients, the procedure was done between 7 weeks to 10 plus 6 weeks. 18 patients had the procedure between 11 to 14 weeks, and 11 to 14 weeks is the time we actually prefer to do the procedure. And we had 2 cerclages which was done between 14 plus 1 to 18 weeks. We usually prefer spinal anesthesia for this case, but 4 patients requested us for general anesthesia and it was given. The blood loss was less than 10 ml in 20 cases. It was between 11 ml to 50 ml in 3 cases, and it was between 51 ml to 100 ml in 4 cases. The mean operative time was 37 minutes. Post-operative hospital stay was 2 days, and progesterone analog was used in 15 cases. The mode of delivery was elective cesarean birth in 21 cases, emergency cesarean delivery in 5 patients, and 1 patient had miscarriage.
Our experience suggests that the transvaginal cervical cerclage can prevent preterm birth, as you saw. It is just a further higher placement of the cerclage compared with the Shirodkar. The difference is, unlike in the Shirodkar, where he pushes the bladder up, we push a little higher, and we access posteriorly the Paucho Douglas. Our results are similar to the ones described for abdominal cerclage. For example, the Maverick trial, which is the most celebrated of one of the recent trials, they had 36 out of 39 pregnancies carried, that is 92% beyond 32 weeks, whereas we had 26 out of 27. So in the context of an 8-year single center experience that we have presented, with a sample size which is not all that great, we would suggest that we need this to be taken up with more centers and prove that this is a viable option, less expensive, less complications associated with it, and that is our message. The vaginal cerclage results are similar, if not better, and it can be done under regional anesthesia. That's the main advantage. Less morbidity and expense. Patients after this don't have to be put head low. They can go to work. They can have normal pregnancy care. Even sexual contact is allowed. And even in early dilated cervix, we can do it. Actually, our next paper is going to be the same cervical mixed cerclage in those with dilated cervix. But that's the next one. So high intraperitoneal cerclage should be the method of choice for those who have failed cerclage before. I don't say that that should be the first line. Especially for those who have failed cerclage before, we would think about higher cerclage, and that can be placed vaginally in the intraperitoneal level. That is our suggestion to you. Thank you again, Krishnendu and other chairpersons, Parag, Sunita, and all our office bearers for allowing us. Thank you, Sujata and Radhika, for this operation. Thank you very much.
Thank you very much, sir, for this wonderful presentation. And it is definitely revolutionary. And what was nice that you made it very clear that this is not the first step in failed cerclages, yes, but how many failed cerclages? And of course, you have to be very confident about your surgical skill when you do this procedure. And I'm sure we have our editor-in-chief, Dr. Sujata here, and Parag. So I think let her have the first say, and then we can follow up with whatever needs to be said. And thank you, Sujata, for giving us this opportunity. And thank you, sir. It's an honor to be present here and even comment about your revolutionary work. Thank you, sir. Yes, Sujata.
Thank you, Krishnendu. Anytime and always welcome. I just wanted to tell Dr. Paili that, posterior, whenever we do Shirotkas, posteriorly, we would take only one longitudinal incision and go only up to the cervix. We never dissected right till the uterosacral. Now that I saw it today, that you take a transverse incision and go right up to the uterosacral, I think in case I have a patient, I'm going to try it next time in case that patient needs an indication of that. And thank you so much for giving us an idea about how to do this vaginal cerclage, and that to highly placed vaginal cerclage rather than doing an abdominal one. Thank you so much, sir.
Yeah, thank you, Dr. Paili. In fact, it was very, very interesting and inspiring. When you present it, of course, it is not very easy, but then it is doable. So for an obstetrician sitting across in the country, it is something which we can definitely attempt because we are used to doing vaginal cerclages. This probably would require little finesse to begin with, but then this is an idea which is really applicable to all across the country. There are a couple of questions for you, sir, in the chat box. If you could answer them.
Should I read out the
Archana
question,
Basir
sir?
also wants.
Yeah, please do. Please do.
I just
Parag,
wanted
sir,
to
should I
say,
read out the
one
question?
second, Pranav, do you infiltrate before taking a transverse incision posteriorly, or you just straight away take it, doctor?
We do, as I was showing in the video, we find out the space between the two uterosacral ligaments.
Correct, yes.
You can even slide the peritoneum there. Infiltrate, not too much. If you push too much, then the peritoneum will be pushed radially.
Correct. That's what I wanted to know. So infiltrate very little, doctor. Yes.
Very little superficially.
Okay, fine.
Hold the whole thing with an ALIS and then cut rather than incise and then go on. Then the peritoneum will go higher and higher.
Correct.
So hold the whole thing with an ALIS and then cut as was shown.
Okay, fine.
Sorry.
Thank you, doctor. Yeah, Pradna, go ahead.
Yeah. Yes. So the first question is how to reach beyond the uterosacrals if there is no descent. Won't there be lots of pulling on the cervix?
Actually, no, because those who are used to non-descent vaginal hysterectomy, this should not be a problem. What you do is just hold the posterior lip of the cervix and pull it anteriorly. So you have the posterior fornix open there for you. Feel the space between the two uterosacrals. Rather than making just an incision, as I told you, with an ALIS, you grab the full thickness of it, in which the pouch-douglas peritoneum also will come. Sorry, sir, some building work going on. That is why for the disturbance we are sorry. So it won't have much of a problem.
Okay, sir, is there any difficulty in removing the suture in LSCS? That is one question for you, sir.
In LSCS, once the baby is out and the uterus has come down in size, you just intubate the uterus, get the uterine body out, and there you can see the cerclage in the pouch Douglas over there on the posterior surface of the cervix, which is not at all difficult to see it because the knot is posterior, so it makes it easier.
Okay. The third question is how to remove the stitch if the patient wants a vaginal delivery.
Yeah, if we have to remove, suppose she hasn't gone beyond 28 weeks, all that we do again is open the pouch Douglas transversely after local infiltration, and there we can feel first and then hold it because we leave the two ends a little long, about 2 centimeters length beyond the knot on both sides, so it may be able to grab it. We also have other modifications of these techniques. One is to leave a tag on that so that with the non-absorbed suture material, so that in case she has to get it removed, suppose
Hello.
I'm sorry because of the building work going on behind us. That is, I have no control over it. That is why. But anyway, we can pull on it and then cut it. That is what we would suggest.
Hello, sir.
Hello.
I'm Dr. Archana Baser here.
Hi,
And
doctor.
I vouch for your method. I've done it in 10 cases. And if you remember, I spoke to you. And this is an excellent method, I would say. Anybody who can do a vaginal hysterectomy can really do it. And I mean, sir has shown an excellent video. And it is an alternative to laparoscopic because laparoscopic cervical cerclage, not everybody can do it. That requires a lot of equipments and skills. But like this method, it can be practiced, and even at the periphery level, means where there are not much resources, they can do it. And recurrent second trimester abortion, this is a blessing. Your method is a blessing, and we have really vouch for it, and we have done it, and we have got the good results.
Thank you, Archana. Thank you for endorsing it. And I would suggest that we should have a little longer bladed straight retractors. That will help. Even levers can be used, but straight retractors will be better so that you can retract and see better.
Can I just
So
make a
can we
comment,
use
Doctor?
yes, ma'am.
Dr. Pali, I have one regret that I did not learn vaginal surgeries from you, right? And but I admire your surgery. I like your paper, but I have few concerns, right? Everybody is not a very good vaginal surgeon. One thing, so everybody may not be able to. And pregnant uterus, there is so much of bleeding. Dissecting the bladder and posteriorly pouch of Douglas opening may not be easy in every single case. One thing. Secondly, how justified we are in injecting vasopressin in a pregnant patients, two things. Thirdly, um, uh, in laparoscopy, when we are doing a cerclage, we are not holding cervix. These are the patients, where cervix is short, you would not like to pull on the cervix. So you're just doing, through the laparoscopy and you're not handling cervix. In vaginal cases, you have to hold the cervix, pull it down to dissect, then pull it up. So these are my concerns, if you could.
Thank you, Manju, for sharing them. It's quite natural that somebody who's not used to will always have all these concerns. First thing is about holding the cervix and pulling on it. If it is not a disturbed pregnancy, there's no need of worrying. But you should not hold it with sharp instruments. For example, a Valsalem you should not use. Even ordinary Alice with teeth will bite into it, and when you remove it, there can be bleeding. Whereas a Babcock will not. So we have modified our Alice longer, 8 inches long, and instead of the teeth coming like that, there are grooves on both sides, like in Babcock, so that it will not pierce into the tissues, no bleeding when you take it out. The second thing is your concern was about giving the vasopressin. I can only tell you, if it is not that much as to cause the problem with vasopressin, as all of you know, is not the hypertension part. It is the bradycardia that can happen. That's a worry. So if they don't go for that, there is no concern. And we can share with you our series of cervical dilated cervix up to about 8 centimeter even. We have been able to bring it back and then put cerclage same way like this. But that, of course, I do admit it needs little more modification of technique, how to get the membrane back in and all that. That I don't want to go in now. But no concerns about this vasopressin, because we have been using this now at least for 10 years, vasopressin use, and minimal dose, not too much, not interfering with the maternal circulation much. That is the point that we have to be careful about. Now, the regarding the handling of the cervix, no reason to be worried about it, because if the service is short, as can happen in many of these cases because of previous cerclage failure and all that, still you should be able to get it with the Alice health. But if you are concerned it's a very short service, we would suggest interval cerclage. Do it between pregnancies so that handling will be, you are less worried about handling that. Thank you.
Thank you so much, sir, for answering all our queries. I think the last query was the same about vasopressin use.
Yeah, Pradnya, may I
Yes,
just add a comment to this?
Yes,
Just
ma'am.
one comment. I think Dr. Archana, she has done 10 cases. So with the number of cases that Dr. Piley has already presented, it's a good idea probably to collate the other surgeons who have undertaken this procedure so that the sample size can be increased and we can have multicentric outcome of results. So that is number one comment. And another query was, so after doing this, we have now actually gone into the peritoneal cavity. So did you consider giving her antibiotics, and if so, for what duration, which antibiotics?
Cefazolin is the one that we give. One injection just half an hour before the surgery we give, and that is all that is required. No tocolysis to follow, because
yeah. Fine. So my query is, did you face, these are a series of 48 patients over a period of 8 years. So we
27,
have
27.
also
27 patients only, ma'am.
27 over 8 years. So did you also come across any cases of peritonitis, or did any of them have infective morbidity, so to say, actually?
None of them actually. Out of this, no, I told you about another 21 that is with the dilated cervix. That is not yet published, that is not included in this group.
Yeah.
This is those failed before. Cerclage failed, and we do it either after the NT scan, or 4 of them were interval cerclages. So 23 of them were after the NT scan, or the level at which it was done. I have already told you the period of pregnancy up to 14 weeks we have gone. Some of them went to get it done because they had to travel abroad and all that, even at 9 weeks. 4 of them were interval cerclages. So in these patients, no worry about no peritonitis, no concerns about that. But in the 21, which we are going to publish later, the open cervix, membrane exposed, even in them, peritonitis was not a concern for us. We give more antibiotics. Exposed membrane we give more. Here is elective, and no, just prophylactic antibiotic, perioperative. That is all that we give. And they are not made to lie down for long like that. They can go to work and all that.
Dr. Bailey, I had one more concern, In 3 of your cases you have done, when patients were between 7 to 11. Normally we do NT and we scan at 12 weeks, we rule out all the, malformations, and then so why did you should remove these 3 cases from this group? This is what I feel.
Those were the ones where they are pregnant, but they are, working abroad and things like that. So after explaining to them that you have to have all the care, the NT scan and all that, but because they have to travel abroad, we did it before the NT scan. That is why.
Okay, Pradnya, I think we can start the next one.
Yeah.
Thank you, doctor.
Ma'am, there's a last question if you want to take it. How is the result as compared to Shirotka's technique with Marcelin tape? This is the last question. So if you compare the result.
Yeah, see, the Shirodka result is actually only about 62 to 80%, like that. But here we got 96%. And this material that we use for cerclage is only, no silk or anything, only tape. But the problem was Mercilin tape, that's a Johnson & Johnson product, again went out of the market for a while. So we had to depend on some other brands like True Bond, Adva Bond, all these are there. There's a difference with the weaving of the mesh between Marceline tape and these ones. Unfortunately, in the true bond as well as to some extent the Adwa bond, when you do the cerclage, leave the cerclage there, the fibroblast can grow into it. Whereas in Marceline tape, it forms an envelope around the tape. So when you want to remove it, you just cut it, it will come. Whereas true bond, especially if you do it, the part inside the tissue will not yield, will not come out. That problem is there. But unfortunately, the cost difference is so much. And we can have trocar instead of the needle. You can have the Marceline tape without needle, which will make it much cheaper. So depending on the affordability, you can modify, but tape is the answer. We don't recommend doing with silk or with proline materials like that. It has to be tape because it's flattened surface, no constriction at that point. Cutting through will be much less if you use the tape. If you use a suture material like proline, there is a risk of it's cutting through into that material. That is, even though monofilament has the attraction of not harboring bacteria, but this is the problem that we have found. And somehow with Marceline tape used for cerclage, we haven't had infection as a worry. Unlike when we use Marceline tape in other parts of the body, we have for a while before tried for other purposes Marceline tape. For example, earlier on lab Khanna procedure, we used Marceline tape. We had problem with infection, but in the cerclage situation, we haven't found as a concern.
Okay, thank you so much, sir. If you have the time, you can answer to two other questions in the
Please,
chat box.
I have time. You want me to
Yeah.
write it? Is it? Yeah.
Yes, sir, if you could, because we have the next speaker waiting. So
Okay,
we'll
please
move
go
on
ahead.
to the
I will
next.
answer this. Yeah.
Yeah, yeah. If you can type the answers in the chat box. Next,
sure.
I request the chairpersons to introduce our next speaker, Dr. Oshadi.
I think Dr. Manju can do that, please. Dr. Manju?
Okay, yeah. So
Please.
it's my pleasure to invite Dr. Ushadi Latmini Nalapurama, a very difficult name for me to say, sorry. She is a faculty of medicine from University of Sri Lanka, and she has got many research awards. She has recent publications, and she is doing ongoing, research. So over to you, Dr. Ushadi, for your next paper.
Hello, everyone. Can you hear me?
Yes, yes. Please go ahead.
Okay. Thank you so much for inviting me and having me at this very interesting research forum. I'm actually a beginner to the world of academia and research, and I feel that I'm very privileged to be here today. And thank you for selecting my paper for the discussion today. I hope you'll not be bored. Can I share this one? Give me a sec.
We can see your screen now.
Okay, that's great. So the topic today that I'm going to present is one of my papers, Adverse Outcomes and Clinical Associations of Dengue in Pregnancy. And this is a retrospective cohort study. And these are my co-authors, Professor Hemant Senanayak and Dr. Janaka Godevitana. So the study, why we did this study is because the Sri Lanka, I think this situation must be quite similar in India also. We face a huge burden of dengue all around the country. And the year that we thought of doing this study was 2017. And that particular year, if you see to the right side of this slide, you will see the dengue was one of the leading cause for the maternal mortality in that year in our country. So that's what triggers us to think of doing this study. And just to introduce a little bit about dengue, you all know that it's a mosquito-borne infection. And there are three distinct clinical entities that we divide. This is from the Sri Lankan and the WHO guidelines. So one is called dengue fever, and the second one is dengue hemorrhagic fever, and third one is dengue expanded syndrome. The latter is actually a very rare entity where there's multiple organs, the kidney, liver, heart, or brain is involved, which happens very rarely. The pathophysiology of dengue is, the virus make actually the body's inflammatory response to go high. And because of that, the vascular permeability increases, and this leads to leakage of plasma in the third spaces. And there can be thrombocytopenia, which is due to bone marrow suppression and coagulopathy. And turning back to pregnancy, we all know that pregnancy also quite same in that aspect, where you get reduced peripheral resistance and increased plasma volume, leading to leakage of plasma. So, there are two conditions which actually with totally different mechanisms, but has kind of very similarity. And in pregnancy also, we know there's sometimes thrombocytopenia. And all these issues make the diagnosis and even the management of dengue difficult in pregnancy. So our objectives were two main objectives. One was to assess the maternal, fetal, neonatal outcomes of dengue. The second one was to see whether there's any predictors that we can come out with from either clinical or laboratory parameters. So what we did is we selected two tertiary hospitals, leading tertiary hospital in Sri Lanka, namely the National Hospital of Sri Lanka and the Disoisa Hospital of Women. And in the year 2017, we took the total cohort of pregnant women who were infected with dengue. And they were confirmed by either NS1 antigen or IgG, IgM of dengue. And once they were identified, so we went through the medical records and then went through the details about the presentation, the dengue acute episode. And then we excluded whoever had any previous known complications of the pregnancy, because they can be having some confounding. And then after that, we followed up that total cohort until and we went through the medical records to see how they had their delivery and until the discharge from the hospital after delivery. So we had exposure variables in these groups. So the clinical presentation where they had the symptoms, the headache, myalgia, arthralgia, retroorbital pain, like that. And the laboratory findings, we took all the findings. And then we took the severity of the dengue according to those previous classification I mentioned, and the trimester of infection. We took lots of outcome measures, and broadly we can categorize them into maternal outcomes, fetal outcomes, and neonatal outcomes. Results. So as I told you previously, so from these two leading hospitals, for the whole year 2017, we went through 326 fever-related admissions. In Sri Lankan setup, I think the same in the Indian setup, where we record things in paper. Unfortunately, we don't have a digital computerized system to store. So it was very difficult to gather this data. But however, we have an infection control unit where they keep a record on all the admissions with any considered any infection. So we went through those records to identify these cases. And then we took the laboratory confirmed one, and we could identify 115 cases. And good thing about this study is that we were successful to follow up 110 out of those 115, and with the only 5 who were lost to follow up. And then the category we had, so we had 73 cases of dengue fever, 39 cases of dengue hemorrhagic fever, and 3 cases of dengue expanded syndrome. So from this population, we had a median age of 28 years. And the range was, so majority were actually in the age group 20 to 30, which was 59.1%. And the majority actually were nullipara, 42.6 were nulliparas. And we analyzed the age and parity distribution among the two groups, positive for adverse outcome and negative for adverse outcome. And they were not statistically different. And this analysis was to minimize the confounding bias, because we all know age and parity can be confounding with adverse maternal and fetal outcomes. So this is how the case load were distributed among the year. Sri Lanka, we have 2 monsoons. So one is significantly happening in the May to September. And you can see, being a vector-borne disease, the mosquito-borne disease, the the spike of the fever cases were in that monsoon period. So from the clinical analysis, the commonest the admission presentation was fever, and it was 96%. And the other important thing is from this, there were 4% actually who did not have fever, even though we consider dengue as a cause that we think always it comes with fever. But there were some patients who actually did not give a history of fever, but they still had dengue. And the second, they had myalgia and headache. And the first investigation that we do when we get a dengue patient is checking for the platelets. And from that, 80% of the dengue fever patient had less than 150, which was the cutoff for the pregnancy, lower than that. And all the patients with dengue hemorrhagic fever had low platelets. And the next one we usually do is the AST/ALT, so the transaminases levels, and we could see the elevation of transaminases level in 65% of the dengue fever cases and 87% of the dengue hemorrhagic fever cases. Average hospital stay was about 5.8 days. So that means you can see how much burden of the dengue to a hospital. So these are the adverse maternal outcomes that we recognized. So out of that 115 cases, 27.8% had some form of adverse outcome. And unfortunately, there was one case of maternal death due to dengue. And there were 19 ICU admissions. And you can see all 3 DES cases were admitted to the hospital. And out of these 3 dengue expanded syndrome cases, there were 1 case of dengue encephalitis and 2 cases of dengue hepatitis. These are very rare entities. And all the 3 cases got admitted to the hospital, and they were basically managed in the ICU for the most of their stay in the hospital. There were antepartum hemorrhage, 1 case, and there were 4 cases of PPH. And the red cell concentrate transfusion were in 9 blood products for another 6. And there were precipitation of labor for 19 cases. And this was actually mostly significant seen in the 3rd trimester. So because the fetal and neonatal outcomes were small in number, we pooled them together for the easiness of analysis. Out of that 110 followed up cases, we had 101 live births. For that 101 live births, there were 2 first trimester miscarriages and 2 second trimester miscarriages and 5 intrauterine deaths. There were 28.7% neonatal rate of neonatal complications. There were 9 cases of meconium stained lipo, 14 cases of NICU admissions, and there were 2 recorded cases of neonatal dengue. Luckily, we didn't have any neonatal deaths. There were 13 cases of low birth weight, and the total live births was 101. And then with the outcomes, we analyze the associations, because the number of the neonatal and the fetal outcomes were less in number. We could not, they were pooled together for the analysis. And these predictors are for the adverse maternal outcomes. So one good thing that we could observe from this study is severity of the dengue was statistically very significantly affected with adverse maternal outcomes. I think that is quite understandable. And the 3rd trimester of the disease was statistically significantly affected to have an adverse maternal outcome. The next 2 parameters are actually new findings from this study, which is one thing was that low platelet count was statistically significantly associated with adverse maternal outcome. So is the high AST. So these 2 parameters are the ones that we think in future, if we can make a more study with larger numbers, this would be the way forward to see whether we can develop a prediction model using these parameters. So coming to the discussion, so from the study, one thing that we realized is obviously the seasonal distribution of the disease. So mosquito control measurements should come in first to tackle this huge issue. And comparing this, our maternal mortality ratio to the Sri Lankan the statistics from the same year, the maternal mortality of the study was very high, having 1 per 101 births. Comparing to the international studies, there were some studies about the dengue in pregnancy where they reported that even the first trimester of infection was associated with complications. But however, in our study, we didn't observe anything like that. Most of the cases where they had first trimester dengue, they had, if it recovered, then they had uneventful rest of the pregnancy. And the third trimester pregnancies, in contrast, was associated with significant complications, and especially dengue had a precipitation of preterm labor if it was developed in third trimester. The PPH risk was compatible with the other studies from the international and the local literature, and so is the blood transfusion requirements. With regards to the fetal adverse outcomes, the IUD rate was significantly high compared to the intrauterine death rate for the national average, which was 1.2, and the study one was 8.1. However, the numbers are small, and so because of that, it's very difficult to extrapolate this finding. The vertical transmission is another concerning thing that it is already described in literature. But however, I think, when there's a patient with ITP, we always think that delivery, the baby will have a risk of intracranial bleeding. So we would not go ahead with very mid cavity rotational delivery or a complicated birth. So we try to keep things minimal. So I think just like that, if the mother is having dengue during the time of delivery or immediately before that, it's a good practice that we take this also into our clinical practice, that the baby may be having dengue, so we need to think of the baby having thrombocytopenia and having bleeding risk, so to cause the minimal birth trauma to a baby with maternal dengue infection. So the strengths and limitations of the study. So good thing is that it's a complete cohort, and it's a good follow-up. We had very less amount of loss to follow-up, and it was a real-world setting one. So you can see there's not some kind of research setting, so the extrapolation would be much better. And we always adhere to the international categorizations for all the trimesters and the dengue, so that anyone can take this data to have another research from anywhere of the world. The limitations, one main thing is that because of the retrospective design, it has inbuilt issues, like the details we gathered were from the medical records, and the intention of recording in medical record is not for the research, that is basically for the patient management. So maybe even though we think a headache is the commonest finding or clinical association, maybe that the patient actually had different symptoms, but the medical record never had that in the details. So maybe things like that. And then the numbers are small, so we can't apply robust statistical methods for this one. Other thing is we didn't have a comparator group. So because we only took the affected sample, we didn't have any matched sample, obviously because it was a retrospective design. So to conclude, there is high maternal and perinatal morbidity with dengue, and the third trimester infection and severe dengue are at high risk of having these adverse outcomes. So there is a necessity to develop early warning protocols and have dedicated management guidelines. And the way forward is, I think, taking this as a ground baseline study, we can develop more prospective studies with comparator group in a large scale numbers, maybe multicentric, so we can have a better understanding and develop some predictor models. That's the study. Open for questions.
Can we have comments from the chairperson?
I think it just shows how scary dengue can be, because we also come, being from Calcutta in the eastern part of the country, dengue is a huge problem. And we always are extremely worried whenever, especially anyone gets dengue, but then more so with pregnant patients. We know that the neonatal morbidity and the mortality is really, really, really high, especially, and we have to be very careful with the mothers. Dr. Manju.
So, Dr. Shadi, I must congratulate you for this study.
Congratulations.
Because, yes, it will tell in the real world, about the epidemiology. But, I have few questions. So some of the patients, they get discharged. How did you follow them up? Could you follow them up? Or no, it was only those patients who delivered, you have taken them only?
No, we have followed every patient. It was very difficult, to be honest, because we have paper-based system. So what we did is we took the details from the admission for the dengue episode, and then we went through the, from the EDD, we have a system, we record all the births. So we went to the admission books and the record birth books, and then we went to find out when they delivered, and then from there we got the delivery details. And for the missing, there were some patients who were actually transferred from, like, this was a hospital usually transferred complicated patients to National Hospital, and we followed up from there also for the medical boards. And then, so the delivery details were gathered like that. And for the patients that we couldn't get from the medical records of the hospital, because some patients were transferred to monitor the dengue, but they did not deliver in our hospital. So we took the telephone details and the addresses, and then we contacted them and got their details about the delivery. So it was got all the patients were followed up.
So, Dr. Shadi, another thing, that platelet falls 48 hours after patient is afebrile, right? So I think that would be a lacuna in your kind of study. We would not know the real this thing. Another thing, and some few of the prospective studies, and it is a well-known fact, that almost 18% patients are 15 to 18, they'll end up in a acute kidney injury. So none of your patients had that. Maybe we are talking of genetically different, in India, people are different, in your countries, or maybe, it's just because it's a retrospective study. Another thing, 14 to 15% of patients, they land up in ARDS and they need ventilatory support. So that part was also I did not see in your study. And 50% of patients, they deliver within 1 week of getting dengue. That's why preterm labor is so high. That part also I did not see in your study. And maybe it's because of the retrospective study, whatever data you could collect, and that's it.
Yeah, thank you for that comment. So actually, the preterm labor precipitation we also observed that was in the subcategory where they had third trimester infection. The preterm labor precipitation was high as 35% in that subgroup. So not from the total group. And regarding, sorry, what was the second comment?
Kidney injury, ARDS.
Yeah. Anyway, I don't know why, but we didn't see that one. So we had there were 2 patients with dengue hepatitis. There were 1 patient who had dengue encephalitis. But during this 115 cases, we didn't see any ARDS or the kidney injuries, luckily.
Thank you.
Any comments from Sujata Devi ma'am or Dr. A.G. Radhika? So thank you, Dr. Ushadi, for sparing your valuable time and presenting this excellent paper on dengue in pregnancy.
Thank you again for inviting me and having me today.
Yeah. So should we go to the next session?
Yes, Pratnya.
I thank all the chairpersons for attending this session. And
thank you very much.
Yes. Now I'll be sharing my screen. Dr. Oshadi, can you stop sharing the screen? Yeah. So my topic for today is AI literature review, how to automate evidence synthesis using ChatGPT and Elicit. So these are AI tools. So I have
Sorry
made
to interrupt you, ma'am.
Yes.
Your screen
We
is
can't see your screen, Pratnya.
Yeah. Can you see now? Hello, everyone. Can you see my screen now?
You can see Google.
Yes.
Yeah. So my screen begins with Google. So what I have done is I have just recorded around 10 minutes video because the internet may be lagging and I didn't want, and of course because Tuesday is my emergency day too, so I didn't want to get held up in an emergency and not be able to present. So I'll be happy to share, answer any questions. I have a 10 to 12 minute presentation on how we search in the regular way and how to search it using ChatGPT and Elicit. So I'll just begin the video. Let me know if you can hear the video. Hello everyone. Today I'm going to show you how to do literature search using artificial intelligence, how to automate evidence synthesis using ChatGPT and Elicit software. So normally when you want to research a particular topic, what we do is we Google that topic. So if I want to write a literature review on treatment of gestational diabetes mellitus, what will happen is I will go to Google. So when we open Google, we can see that we can get lot of information, but it is either from a clinic, it is an original article, it could be a paid promotional video by an individual doctor. So all this may not be important for me when I write my literature review because these are not all scholarly articles. So what I do is, if I want to search only scholarly articles for my literature review, searching on Google is not enough. So the next step is I go to Google Scholar. So if I go to Google Scholar and I type the same topic, that is treatment of say gestational diabetes mellitus, I will get all the scholarly articles on this topic. So I can refine my articles by using a timeline, I can customize a range, I can sort by date, I can include review articles, I can include the citations of that. However, Google Scholar may not have the full text of all these articles. So it is missing for this particular article. So what if I want the full text of all the articles? Maybe I will have to go to a site, a search engine which will definitely give me full text. So usually we go to PubMed. So what we can do is, if I want the full text of these articles, I will go to PubMed and I will search for that article, which is I will have to search for treatment of gestational diabetes mellitus. So I can search PubMed using this. So what I can do is, in PubMed also, I can refine my search to the years. I can choose a publication date. I can see the text availability. Suppose I just don't want abstract, I want the free full text. So now it has shown me a search of 13,258. If I use full text, so only 5,685 articles have full text. So that is the way. Now I might have certain articles where gestational diabetes may not be the main concept of that articles, but it is mentioned. So if I want gestational diabetes should be the main concept of that article, what I can do is, in PubMed I can search it through the mesh, which is the medical subject heading. So in the PubMed site we can go to mesh and I can search for gestational diabetes mellitus. So if you go there, you can search. Okay, once I type search, I find that there is only one medical subject heading, which is gestational diabetes. So I can choose that and I can add it to the search builder. Now there are Boolean operators and or not. So if I want articles which have say diabetes mellitus and say fetal growth restriction, so what I can do is I can type that fetal growth restriction. So I can search. So, and I have this fetal growth retardation, okay, as the medical subject heading, and I can add it to the search filter. So now when I search PubMed, I will get articles which have both. So there are 463 articles. So mind it, this is a very tedious process where I'll have to go search, I'll have to open every article, I have to read it, then I'll have to summarize the article, I have to make a chart of the important findings. So I'll have to read 463 articles. It will be a very tedious process and I'll have to go through everything. And also, if I want only the main evidence is from Cochrane or meta-analysis. So if I search Cochrane database, then I can go here Cochrane and then we can type the same in the search, okay, and we can search for treatment of GDM and I can search for Cochrane review, okay, and this way also we can get all the meta-analysis. So I have got 240 results, okay, and I'll have all the Cochrane reviews, systematic reviews which are there on this particular topic. However, this also will be quite cumbersome to go through all the 240. The other way I can go is use artificial intelligence. So what I can do is I can go to ChatGPT. So what will ChatGPT do is I can go to ChatGPT and I will open it. Okay. So this is the ChatGPT page and it is asking me how it can help me. So what is important here is you have to give a good prompt. If you give a good prompt, you will get good result. So I will say I want to write a literature review on treatment of gestational diabetes mellitus, and I want ChatGPT to give me kindly prepare make outline for that review and structure. Okay, outline and structure for the review. So what ChatGPT will do is it will prepare a draft for me in which it will list all the topics that I have to write. So it will involve introduction, methodology, databases search, first line management, medical nutrition therapy, physical activity, behavioral, pharmacological therapy, insulin therapy, oral hypoglycemic agent. So all these are headings that I can include in my literature search. Okay, then there are guidelines, challenges, gaps. So utilizing all this outline, what I will have to do is I'll have to search relevant references. For example, I can use, suggest references for definition of GDM. So in that definition introduction part, I can utilize those references. The next part maybe I can use, suggest. So if I take this sub question, so what we can do is we can search literature, suggest references. So I need original articles, references, original articles for this topic. So if I go here, it will suggest me, it will search the web and it will come across so many literature references. So these are all the references. So all this is information. So you can here list the references in Vancouver style or format. So here you will have the Vancouver references for this particular topic, which is medical nutrition therapy. What is important here is sometimes ChatGPT may give you fabricated references. So it is very important that we go in each reference and verify its authenticity. So what we do here is we can select this first reference, put it in Google Scholar, put it in PubMed, and we can search this particular topic. We can search for this article. Sometimes the title may be there, but the author may be different, the journal may be different, the page may be different. So it is very important that we verify each of the references, because sometimes it may all be fabricated. Now if I want only Indian data, only Indian studies, so it will do that. Okay, it will give me only Indian studies on this topic. It is searching the web, and if you can see, I have got all Indian studies. So this way it will help us to get lot of references for this topic. Okay, I can ask to suggest more references. Okay, so it will search more references regarding this topic. And what is important here is that we give the proper references. So what we can do is, we will go on every particular topic and we can search for literature on the, say, oral hypoglycemic drugs or insulin therapy and oral hypoglycemic drugs. So we can choose this and we can put all this using another artificial intelligence software, which is Elicit. So what is Elicit? The full form of Elicit is Evidence Literature for Contextual Insights Too. Okay, so I'll go here on Elicit and I can, so this is the Elicit page. So you have recent searches. Okay, these are the searches I have already done. I can open a new notebook, new research report. So there are two versions. There is a free version, there is a paid version. So you can do many things even in a free version. So you can add papers to the library. Suppose you've already searched topics, you can upload papers here. You can even connect your Zotero to this Elicit and you can add more papers to this library. So I'll go here, library, and you can add that. Now new notebook I want to prepare. So I want Elicit to suggest references for my oral hypoglycemic agents and insulin therapy. So once I go there, it will suggest me references for insulin and oral hypoglycemic. So what happens in a free version, you always get the summary of the top 4 papers. In a paid version, you get summary of the 8 papers. So I can go here. So oral hypoglycemic agents, insulin remains the gold standard. So if I click on this reference, I will get the whole paper. Okay, I'll get the abstract, I can get useful information about this paper. Then I can go to the second line, and what does it show? That metformin shows comparable efficacy. So I can go to this particular article and I can confirm what is there. Okay, so by the DOI number also you can search these articles and verify whether they are authentic. So I will get these references. So what happens below is, you can see all these papers are in tabulated format. So this is the paper and beside it is the abstract summary. So I can either sort by most relevant, most recent, less recent, most cited, least cited. I can arrange them in alphabetical order because certain journals require it by all alphabetical orders. Then I can use articles which have complete PDF. I can choose the publication year, the quality of the journal. I can use systematic review and meta-analysis only, or I can use only RCTs. I can choose whether the abstract has, say, metformin only. I can exclude those who have insulin. Like that, many modifications can be done. So we can limit our search like that. So this is the abstract summary. So if I want, along with the abstract, I want the outcome measured. So I can add that column also, and it will give me all what outcomes have been measured in that particular study. Suppose I want to add the methodology, or I want to add the limitation. See, column limit is reached. So in a paid software, I can only do it 2 columns. So what I can do is, I can remove this column. Okay. I can remove the outcome measured column, and I can add limitation. So like that, step by step, we can add and delete lot of things. The only thing that we have to maintain is the columns, have to be 2. Now what we can do is we can go and search these papers, we can add questions to these papers. So how we do it is that we can go down here, you can see here, I can select say 2 to 3 papers. Suppose I like these 2 papers. Okay, these are very good papers. So I want to add a new step, which is I want to create a new table which is having only these 2 papers. So what I can do is a new table will be created which will have only these 2 papers. So very important, if I like certain seed papers, I can utilize that. Suppose I go and I want to have more information about these papers. Say I want to use this paper also. Okay, I want to use 3 other papers. I want to use this particular paper. Okay, and what I can do is what are the other steps I can do is I can chat with the papers. Okay, so I can add a new step. I can summarize the abstracts of these papers. I can chat with these papers. I can ask new question and find new papers. I can extract the data from these uploaded papers. Now suppose what is chat? I want to know about these papers. Suppose I want to know the research gap. So that when I do some research, I can work on these research gap in these papers. So it will suggest me what is the research gap. So I can't use the full text in the free version. So research gap. So what it has showed that it is just synthesizing. So what it will show is that acknowledges that they are safe in pregnancy. However, more longitudinal studies are required for long-term impact. So maybe when I plan a study, I will use a more long-term study. So like that, you can add a lot of steps, you can upgrade. If you buy a pro version, you can use the full text. Now suppose I don't know anything about this topic and I want to get a list of concepts. So basically concept will help me understand. Okay, so concept, broad term, it will not give me the references, concept of treatment of GDM. So it's a broad heading and I will know everything that is required. So to get a broader understanding, so not only for scientific papers, you can use it for a lot other things, and this is particularly useful. Okay, it will explain everything about how GDM is treated. See, diet management, you have regular physical activity, blood glucose monitoring. Then when we go ahead, you will get education, insulin, OHA. So like that, so this will not give me references, but I can understand the topic broadly. Then I can do search and I can even ask them to load more papers. So I can load, and the only thing is you have to verify the authenticity of each and every paper. Now we saw how to go about this. Now we will just see how to get the research report. So they have already done research reports, say for this topic, magnesium effects on sleep and stress. So you can get a summary of the content. Okay, what you can do is you can upload, extract more articles if you have already gone through articles, and we can run this search. So they have already done research. So this is a sample. If you put your questions well, you can also reach a similar outcome, and you can just type all this in your Word document and it will help to synthesize report. So first you see, it gathered papers, it screened the papers, extracted data, about 98 data points. So see, abstract, method, so the results, they have compared all these studies. Okay, intervention, outcome, PICO model, as I said. So lot of things they have compared, various parameters, what sleep architecture was measured. Okay, 4 more rows. So you can get lot of things, direction, intervention, duration. Suppose I want studies only more than 6 weeks, so I can choose that. So in the end, what you get is you will get references like this. You can see here there are references. What you will do is you will select each one and find out the authenticity. You can choose a DOI number. You can see whether this is falsely synthesized or true. So as I said, there is no AI can be used to complement the human intelligence. It cannot completely replace the human intelligence. And if we use AI along with human intelligence, we can do our work much, much faster. And what takes weeks of evidence synthesis can be done in no time, provided you use it intelligently. One more thing that you have to be careful is of plagiarism. If you write as it is, then definitely there are plagiarism softwares which will detect this plagiarism. So I'll just stop sharing. I hope everybody understood how to use this illicit software and AI. Basically, we have used ChatGPT to form the framework, and then each sub question we have put it in the illicit software, gathered evidence. So each topic we can gather four say definition of GDM, references for medical nutrition therapy, references for oral hypoglycemic agents, references for insulin, and we can combine. What we have to be careful is chat GPT will synthesize evidence where there is no evidence in place. So we have to be very careful. Even if it gives you a reference, you have to practically go and check whether it is true, the page number, journal. So please don't go for articles where you don't get the full text or you don't get PDFs for these articles. Our journal JOGI also has authenticate software, and we do a lot of plagiarism checking. So it is very essential you don't plagiarize your articles. So even if it gives you references, don't use a material that has been summarized exactly. You have to reframe it in your own words. The base of the meaning should be the same, but you should not use it ditto. Cut, copy, paste should be avoided. So basically, I would like to thank AG Radhika ma'am. She gave me this topic, and when she told me about this, I was myself unaware about how to use ChatGPT and Elicit, and there were a lot of tutorials also available on this topic, and I really went through it. And I am very sure I can do this research, finding research in no time, because the machine really does work faster than a human, but it cannot be a substitute. Human intelligence is still the most valuable thing, and we can use this artificial intelligence to speeden up the literature search. So I'm happy to answer if there are any questions.
So Pradnya, I think that was a brilliant presentation and a huge amount of effort that you have undertaken to, demonstrate the two softwares amazingly with such clarity. I must congratulate you on the entire presentation.
Thank you, ma'am. Thank you.
Yeah. So, but few points that I just wish to bring forth.
Yes,
So we had started with the topic that was literature search, right? And how good are these softwares for the literature search? So let us come back to that topic. I just wanted people to be aware of the goods and bads of these processes. So now, for instance, if I were to take a topic for a systematic review, idea is to cast a huge net into the ocean and catch all the fish, the large and the small fish, and then be able to sieve out what is of relevance to us. And to be doing in such a way that if I do the casting of the net in India, the results should be the same if someone were to do it in Australia, right? So it's hugely dependent on the search keywords. The search strings, the search method itself takes about 2 months, 3 months for us to develop a search strategy. So that is the case for a systematic review. That's a secondary research where I have collated the results of many primary studies because I want to add good power to the results that I have, the robustness as well as the evidence, and the sample size as such increases. So if the studies are homogeneous and the results are similar, then it really adds trust to the guideline or the recommendation that I put forth. So that is number one. So where all can we are required to use a literature search. So this is one. And we for that we need good robust databases like Scopus, Embase, PubMed, those standard ones where there is peer-reviewed literature, which can be replicated in a literature search. So now, if that was the case, what is the place for Google and the Google Scholar? Now, these are, basically very good for gray literature, the ones which have not been published in good impact journals, and where you want to have unpublished literature, gray, the ones like conference posters. So these are good. Now, what is the place of AI? AI helps you, like you very well demonstrated. If I were to do a narrative review, okay, what you basically showed was a literature review on a certain topic, and I wish to do it fast. Now, is it good for us? Now, for us professionals, we would like to put forth, even if I'm doing a literature synthesis or a literature narrative review, the kind of data that I develop it as a background for my presentation again has to be authentic. The AI helps you to get these in one place. Like you very nicely said, it can never replace what we as humans would be doing. So each of these has to be verified and has to be read, because we can read between the lines. Just a table can actually tell us how good that data is. So the AI will give you as is where is basis, but the derivation of those results has still to be undertaken by you. So, and another word of caution, we have today innumerable number of GPTs. Chat GPT and Elicit are only two kinds of software. You have Scholar GPT, Sora, Canvas. They have different kind of the goods and bads, their strengths and limitation. So this was a teaser, very well presented. Thank you so very much, Pradnya, and that's all from my side. Thank you.
Thank you so much, ma'am.
So
So basically,
can I
thought
ask you one question?
Yes, ma'am. Yes, ma'am.
So you said, Chat GPT will give you so many, articles, right? This thing. Now, when you open these majority of good articles from the good journal, they are not free. Previously, you could put the DOI in the Sci-Hub and you could get the complete article. See, those who
I
are
got your
studying in
message. I saw your message in the
Message,
chat,
yeah.
Dr. Manju.
Anji, Radhika,
Yeah.
so how do you do that? Like, see, you
So
are
the
in a
Sci-
hospital.
Sci-Hub is
Sci-Hub is now
not a good site. It gives
no, Sky has been curtailed heavily by the wings have been cut by the International Court, the
But
justice,
Radhika, then how
Court
do
of
you
ma'am,
get
Justice.
it
complete
gives
article?
So you have
unpublished
others.
articles.
You have other choices. There is something called LibGen. These are all again, they may they come with some softwares which can enter your computer and can hack also. So these are unsafe sites. So I don't want as a person to be speaking in a public forum to be able to give you these sites. But there are other sites which can give you these. And number two, the safest is to either get it through ResearchGate or write to the author and try to get the literature.
Yeah, I was just going to say that ResearchGates gives you an option to write to the authors, discuss that paper. They can share the full text with you. So, you can collaborate your research with so many. In fact, whenever you publish, I urge everyone to put it on ResearchGate so that even you benefit and the others can also benefit from your research. So, ma'am, this is basically, I thought Elicit and ChatGPT can give you a summary of the abstract or what are the main findings. Then you know which are the good papers. So I can put them as seed paper. In fact, there is one more software that I came across. In fact, it's a tool. It's called a lit map. So if I, by going through 10 papers, suppose I like one paper, I can put it as a seed paper and all the other papers I can work around it. So it's a good algorithm and it will take into consideration my seed paper first. And if we buy these paid versions, they can even suggest more papers like this. So what I
Certainly,
presented
Pradnya,
to you was only free version. So if you take a paid version, you get a lot of credit points, you can use them, and a lot of things can be automated if you use the paid version. But I thought so even a free version, you have to do more manual things, but you can still get the same result. So the
I think
only
as
thing
of
is,
now,
yes, ma'am. Yes, ma'am.
no, absolutely, Pradnya, as of now, I think this, everything is in the developing stages. And for us, people who are, in the academic side, we have to be careful because now journals have also started using these softwares, and plagiarism very well said, we don't want to copy things. And also the authenticity of a presentation, we still need to verify whatever we are presenting in a write-up. So while these softwares give you an idea in the direction and probably help you a lot, because literature search traditionally takes many, many months, like I said. So they help you to filter down, funnel down to small and, for maybe, getting a basic idea to get an outline like you had very nicely shown in the GDM literature. So they give you a structured format for your thing. But I would still suggest, I would still encourage everybody to go through the normal route for a literature search, especially if you're doing so for a systematic review, because these may not be the ideal or the best, because these are not reproducible. You see, whatever literature search that we do, through those search strings and the search strategy has to be reproducible. So for systematic review, we have other softwares which are available, but still they have not found a good place. But for a literature review and a literature search, the ones that you showed, they do reasonably well. But again, we have to read between the lines. That was my only thought on the matter. So Dr. Dalvi is also there. Dr. Sujata, would you like
yes.
to?
I'm listening to both of y'all, Radhika and Pradnya. And
Yeah.
thanks for clarifying the whole thing. And good, Pradnya, that you showed the free access, because paid, of course, you get a little better, but then let it be free access so that everybody can use that mode to how to include AI in their literature research, So thank you so much for
Thank you, ma'am.
explaining everything so well. And thank you for whole of today's program, Pradnya. You can give vote of thanks
Yeah.
now.
Yeah, thank you, Pradnya. You really handle all these sessions so well.
Correct.
And
Yes,
a lot of
right
hard
from the
work.
beginning till the end.
And the entire team.
So I'll just like to present my vote of thanks. I would like to thank our Foxy President, Dr. Sunita Tandurwadkar, ma'am, Secretary General, Dr. Suvarna Khadilkar, ma'am, ICOG Chair, Dr. Parag Binewala, sir, JOGI Editor-in-Chief, Dr. Sujata Darvi, ma'am, and convener for today's program, and Dr. A.G. Radhika, ma'am, who is the convener. All the three chairpersons, both the speakers, I think Dr. Paili sir's operative video was the icing on the cake. And he really inspired so many of us to try all these new techniques. And of course, I would like to thank Nilima for being the backbone for arranging all these programs. So we will see you again on the second Tuesday of next month. And thank you so much for giving me the opportunity to present this software. It was a good learning experience for me too.
Thank you, everyone.
Yeah,
Thanks.
thank
Thank
you.
you.
One and all.
Thank you.
Yes.
Right.